everyone. I am Dr. Subarti Kaur, member of the social media team of World Congress of Nephrology. This is our pre-Congress interview session. Our today's speaker is Professor Dr. Paul Komenda, Professor of Medicine, University of Manitoba, Canada. Hello, Paul.
Hello, Subarti. How are you?
I am fine. Let me ask you a few questions. How you get involved in the field of nephrology?
Long story. Always wanted to be a doctor growing up. My dad was a family doctor growing up. And then when I got into medical school, obviously you have to pick specialties, and I chose to go into internal medicine because I wasn't very good at surgery or working with my hands so much, but I was more useful in figuring complex problems out using my brain. I ran into very good mentorship when I was at Western University in London, Ontario, Canada, around nephrology, and then was fortunate to match to a program at University of British Columbia, where I had even more fantastic mentorship there. And eventually, wanted to get into something where I can see patients throughout sort of the life cycle of their treatment. So a lot of specialties, you interact with patients for a specific procedure or a consult, and then you never see them again. Love the aspect of nephrology where I got to follow patients for a long period of time and develop, really truly meaningful relationships with them and their families, seeing through good times, like for example, if they get a kidney transplant, and hard times, maybe when we're telling somebody that they may have to go on to dialysis. So managing that whole spectrum of kidney disease and kidney health has been something that's been a real passion of mine, and truly still enjoy the deep, meaningful patient engagements that I get to do as part of my job as a nephrologist.
Thank you. What inspired you to work on renal health issues of indigenous Canadians?
So I moved back home to Manitoba, Canada. We're sort of in the central part of the country after finishing fellowship, and it's a smaller center in Canada. Our province is about 1.4 million people. What I noted when I came to Manitoba was that although Manitoba is about anywhere from 15 to 20% of our population is Canadian First Nations population, the representation in the dialysis units, there was a far greater number of people of First Nations descent in our dialysis units, and often at a very young age. And I really wanted to explore that problem from the ground up. So I did a lot of initial work on registry work, like how, was this always a problem where all, First Nations people were suffering disproportionately from kidney failure and kidney disease? And in fact, we discovered, looking at about 30 years of data, that it wasn't always the case. So it's not something necessarily genetic or something different about those people. There's obviously something that, in the last 30 or 40 years we're doing differently that had caused this problem, this epidemic. And then I learned a lot working with First Nations partners and so people in healthcare, but also learning from patients and elders in First Nations communities around, why were we seeing this? And a lot of it really stems from, at the end of the day, structural racism in Canada. So the fact that we have a reserve system in remote rural parts of the country that don't have adequate access to primary care or prevention or even basic social determinants of health like clean water, or as we would describe as a healthier diet or more diverse diet, or they really had gotten away from a lot of their traditional diets. And then just really a lot of things in Canadian history that are not something to be proud of, like multi-generational trauma, residential schools, things of that nature. And so you have a whole cohort of First Nations people living in rural and remote communities that have very poor access to basic social determinants of health, poor access to healthcare, preventative care. And again, I often can't fix everything, but in my sphere of clinical nephrology, I found that there's something I could do differently. So instead of building dialysis units, which what we were kind of doing and still do to an extent in very rural, remote parts of Canada, that's very expensive to do so. We could get far greater yield by actually educating people about kidney disease, screening people early for kidney disease, and then getting people assigned to either specialty care following them, but also maybe just getting onto early preventative care initially was basic stuff like blood pressure control or ACE inhibitors or ARBs. And then now we've got such a whole host of other disease modifying treatments that if we could apply early, it's far more cost effective, far better for people to never have to go on to dialysis or get a kidney transplant, or at least delay the need to start dialysis. Dialysis in northern parts of Canada, because of where it is, can often be in excess of $200,000 per patient per year. And it's quite obvious that if we apply, simple screening and education initiatives and combination of lifestyle interventions, if we can, or at least some disease modifying treatments that we have available now, it'll do far greater good than building these dialysis units.
Thank you, Paul. So I learned from your work that this prevalence of CKD and albuminuria both are high in the indigenous people. So why the number is so high in this group?
Yeah, so it's again, from our screening program, when we're screening all comers, about 1 in 3 First Nations people in these remote communities have some form of chronic kidney disease. And if we look at sort of global screening studies that have been done in many places, it's typically anywhere from 10 to 15% in most populations. So we're looking at a 2.5-fold increase in CKD in these people. And again, I think the root cause of that, because we've seen that rise again only the last probably 30 or 40 years, it's really the root causes are social determinants of health, of which the root causes of that again are probably more rooted in structural racism and just inadequate access to exercise, clean water, good maternal health, things of that nature that really are not any fault of any people. But just by virtue of being in very rural and remote locations on reserve with lots of poverty and unemployment and things like that, it's really these colonial structures that have led to that inequity that really are things that are hard to turn around just with a screening program or things like it's multiple generations are going to have to try to improve these situations.
What about their equitable access to dialysis and transplantation?
Yeah, so it's a great question, Shabardi. So I think we've done studies in transplantation. In terms of deceased donor transplantation, the access is pretty reasonable. But in Manitoba, we have a very long wait list for transplantation. So it's people living in a lot of these communities have challenges with living donation. It's very hard if a lot of your friends and relatives may be also afflicted with diabetes or high blood pressure or chronic kidney disease themselves. Living donation becomes far more challenging. So again, our system has a somewhat equal opportunity to get access to a transplantation in terms of like the day you start dialysis is the day you start, your time accumulates on your wait list for transplantation, but it's not equitable in terms of people living in northern parts of the country, very rural, remote, that have far greater hardship when they have to relocate for dialysis. We do have some hemodialysis units that are rurally located in some of these very remote communities. They're very costly to run. We do have the opportunity for home dialysis just about anywhere, but again, that's predicated on housing that's sufficient for, say, a home hemodialysis machine. Lots of challenges with small places where people live to store PD supplies or ship PD supplies to these communities that again often even are not accessible by roads. They're fly-in communities only. So I would suggest that we offer equal access to these things, but it's certainly not equitable. And that's a big distinction we need to make, the difference between equality and equity that people often don't understand. We need to do more for people living in these communities because there's a significant disadvantage that you have by living in poverty in remote communities without access, often by road.
Thank you. Can you give us a few highlights on your talk in the upcoming Congress, World Congress of Nephrology 2022?
Yeah, I think it's just very important that people recognize the challenges of delivering things like dialysis services in very rural and remote communities. I think, especially, the flavor of this talk, there's lots of different health systems represented, and people look at countries like Canada often and say, wow, it's a very wealthy country. Everybody has got all this great access to dialysis services and so on. I remember I gave a talk in Mexico City a few years at their national meeting, and it was often like, oh, you're so lucky in Canada. We should build dialysis units and satellite units like you guys do. And I would suggest that's, if I had to start a system over again and I had to invest in infrastructure, I would invest very strongly and firstly in powerful screening and surveillance systems, like we've done in this case, point of care testing, where you can really test anywhere in the world in about 30 minutes someone's GFR, their urinary albumin. We can risk stratify them. We can potentially connect them with reasonably low cost treatments for at least things like blood pressure and maybe fancier drugs that still are much cheaper than dialysis. And then really invest in robust infrastructure for home dialysis, for being able to deliver, say, PD or home hemo as the need should arise, but not necessarily investing in this whole network of very costly facility-based hemodialysis units everywhere. Because yes, that will always be a need for end of life, but I think in terms of the entire population health, we're going to get far greater bang for our buck by at least preventing or delaying the need for dialysis further in a population, rather than serving very few for high cost with facility-based hemodialysis units, because they're just so costly to maintain and operate, and even the skilled resources required to deliver dialysis is just not going to serve the entire population quite as well.
Thank you, Paul, for being with us, and we'll be eager to listen to your talk during our Congress. Thank you.
Thank you very much for your time. Take care. Good luck with the meeting.